Imagine you are diagnosing a tumor that has completely destroyed its cellular boundaries, wiped out its structural retaining wall, and is just actively proliferating on a slide.
Sounds pretty aggressive, right?
Exactly. Yet, you turn around and confidently categorize it for the patient as a localized in situ disease. I
Yep.
mean, how does a structurally invasive biological behavior end up with an excellent prognosis?
It sounds like a complete contradiction in terms,
Yeah.
especially if you're rigidly applying the standard rules of breast pathology. But that paradox is exactly what we encounter with specific variants of papillary lesions.
Yeah.
We're dealing with this incredibly complex morphological spectrum where the standard binary of, benign versus malignant gets heavily distorted by structural nuances.
And today we are decoding that entire spectrum on our deep dive. We're moving step by step from completely benign intraductal papillomas all the way through the diagnostic gray zones and finally into invasive papillary carcinomas.
Right, drawing heavily on surgical pathology guidelines and that really comprehensive data set from the Royal College of Pathologists.
Okay, let's unpack this. To navigate this whole thing, I want to use a specific mental map for you. If we picture a normal breast duct as a tubular tunnel, a papillary lesion is fundamentally a tree growing inside that tunnel.
I like that. It's a highly arborizing structure. And the primary variable that determines whether that tree is a benign, physiological response or a malignant threat comes down to the microscopic architecture of its branches.
Specifically, we're obsessing over the myoepithelial layer, right?
Exactly. Every single time we evaluate these lesions, we are looking for the presence, maybe the attenuation or the complete absence of those myoepithelial cells.
But before we analyze how that layer breaks down, we have to establish our benign baseline. We need to look at the normal, healthy tree. The classic intraductal papilloma.
Right, so morphologically, an intraductal papilloma presents with broad, blunt fronds. These are robust structural branches, and they're supported by central fibrovascular cores.
And those cores are doing what, exactly?
Well, they're critical because they provide the vascular supply and the stromal scaffold for the entire arborizing mass. Covering that scaffold, you have a perfectly preserved, orderly, double layer of cells,
So that's the inner myoepithelial layer and the outer luminal epithelial layer.
which means the structural integrity of the duct is completely maintained. It's just folded inward on itself into this complex papillary architecture.
Now, the sources stratify these benign papillomas into two main categories based on their anatomic location within the breast. And the location drastically alters both the clinical presentation and the subsequent risk profile.
Yeah, we have small duct papillomas and large duct papillomas.
Let's start with the small ones.
So the small duct papillomas arise peripherally. They're located deep within the terminal duct lobular unit. And because of that peripheral location, they're typically just an incidental microscopic finding.
Usually well under 1 centimeter, right?
Usually, yeah. And you frequently see them as multiple lesions scattered across adjacent TDLUs.
But biologically, they actually carry a disproportionate amount of risk compared to their size.
They really do. A patient with peripheral small duct papillomas has an approximately threefold relative increase in the risk of subsequent carcinoma. You're seeing a localized field defect in the TDLU architecture that hints at a broader genomic instability.
Contrast that with
That-
large duct papillomas. I mean,
Yeah.
those are essentially located in the lactiferous ducts directly behind the nipple.
Right.
They're almost always solitary masses,
Mhm.
and the relative risk of carcinoma drops to about a twofold increase.
Mhm.
But their central location drives a very specific and I'd say alarming clinical symptom, which is serosanguinous or blood-tinged nipple discharge.
The mechanism there is purely mechanical. Think
Yeah.
about it. You have this highly vascularized, arborizing mass growing inside a major central excretory duct.
Like a traffic jam on a main highway.
Exactly. While the small ducts are like quiet suburbs where things go unnoticed, the central ducts are the main highway. The mass is constantly subjected to fluid pressure, friction, torsion. Yeah, so the delicate epithelium covering those broad fronds ulcerates, the underlying fibrovascular cores bleed into the ductal lumen, and you get that characteristic discharge.
So it's essentially a mechanical trauma to the tumor itself. So a patient presents with that discharge, they get a biopsy, and the tissue ends up on a slide. Proving that this is just a benign, mechanically irritated tree requires a very specific immunohistochemical toolkit, doesn't it?
It does. We rely heavily on a targeted IHC panel to interrogate that double cell layer. First, we need to prove the myoepithelial retaining wall is completely intact.
So what markers are we running?
We run markers like P63, P40, or smooth muscle actin. SMA. In a benign papilloma, you will see strong, continuous, positive staining outlining the inner contour of every single frond.
And for the outer epithelial layer, we're looking for mosaicism, right?
Yeah, we're looking for a heterogeneous, patchy staining pattern using CK56 and estrogen receptor, ER.
Why?
Well, a normal benign proliferation maintains a balance of cellular lineages. Some cells will be ER positive, others ER negative. Some will express basal high molecular weight keratins like CK56, and others just won't.
Oh, I see.
That patchy mixed pattern proves you have a polyclonal, physiologically normal tissue response.
But here's the thing. Even though the tissue looks structurally normal and polyclonal, the molecular data in our sources points out something highly counterintuitive.
Oh, the mutations.
Yeah. Roughly half of these histologically benign, perfectly intact papillomas harbor activating point mutations in the PIK3CA or AKT1 genes.
It completely upends the assumption that a known oncogenic driver mutation always results in malignancy.
Right.
In the context of a papilloma, a PIK3CA mutation alone is sufficient to drive local cellular proliferation. That's what creates the mass. But without the concurrent loss of key tumor suppressors, it just cannot drive malignant transformation. It stalls out as a benign overgrowth.
That sets the stage perfectly for the diagnostic pitfalls. Because while a classic benign papilloma is relatively straightforward to identify in theory, the reality of analyzing core needle biopsies is completely chaotic.
Chaotic is a good word for it. Core biopsies of papillary lesions are notoriously problematic.
No.
You are firing a large bore needle into a confined, delicate, highly vascularized structure.
It's like taking a bulldozer to our tree.
Exactly. The mechanical disruption frequently severs the primary fibrovascular stalk.
Which instantly triggers localized ischemia.
Complete ischemia. The entire lesion can undergo complete infarction, just tissue death, or severe sclerosis. By the time that tissue is processed and placed under the microscope, the architectural hallmarks are obliterated.
So you're just looking at mush.
Pretty much. You're looking at a distorted, necrotic, heavily scarred mass, making it nearly impossible to definitively evaluate the cellular layers.
And even if you manage to get an intact sample, the malignant changes like atypical ductal hyperplasia or ductal carcinoma in situ, they don't necessarily take over the entire lesion at once.
No, they can be highly focal.
Right, you could have a 1.5 centimeter papilloma where 95% of the arborizing tree is perfectly benign, and only one microscopic peripheral branch harbors a clonal DCIS proliferation. But wait, if the biopsy needle itself can destroy the evidence, and the dangerous cells might only be hiding in one tiny corner of the tree, how can you possibly give the patient an accurate diagnosis?
This raises an important question, and it's the primary reason behind the strict surgical management protocols. If a core biopsy shows a papilloma, but the imaging shows a lesion over 1 centimeter, or there's clinically concerning nipple discharge, or it's an older patient, the standard recommendation shifts.
Shifts to what?
Complete surgical excision.
Okay.
You cannot rely on a tiny fragmented core to rule out focal atypia. You just can't. You have to embed the entire excised mass and examine the entire tree.
So once you have the entire excision, you can meticulously search for DCIS arising within the papilloma. What are the morphological clues?
They're subtle. Maybe the cellular proliferation on one frond looks more monotonous, or the architecture becomes cribriform. But the definitive proof always comes back to the IHC traffic light system.
Right, we mentioned earlier that benign epithelium has a patchy, heterogeneous ER and CK56 expression. If a focal area transitions into DCIS, how does that IHC profile shift?
It undergoes a complete loss of mosaicism. The cells in that atypical focus will be completely negative for CK56.
Meaning they've lost their basal progenitor characteristic.
Exactly. And simultaneously, the ER staining becomes uniformly, diffusely, and strongly positive across every single cell in that area.
Wow, so it transitions from a normal polyclonal mixture to a monoclonal population restricted entirely to a neoplastic luminal lineage.
That uniform ER positivity paired with negative high molecular weight keratins is the absolute molecular signature of a neoplastic clone expanding within the benign structural framework.
Here's where it gets really interesting. Because once that monoclonal DCIS population fully overtakes the papilloma, we cross a major structural threshold. The physical architecture of the lesion begins to fail, moving us into the malignant end of the spectrum and introducing encapsulated papillary carcinoma, or EPC.
The morphological transition from a benign papilloma to EPC is incredibly stark.
How so?
Well, the broad, sturdy fronds are replaced by numerous slender, delicate, highly branching fronds. The cellular population is monotonous, typically round to spindle-shaped tumor cells, but the defining diagnostic feature of EPC is what happens to the structural retaining wall.
The myoepithelial layer completely vanishes. It's just gone.
It is entirely lost. If you run a P63 or SMA stain, it will be completely negative along the fibrovascular cores of the papillae, and crucially, it will be completely negative around the periphery of the entire lesion.
So structurally, the tumor has completely lost its cellular boundary. It is, by definition, invasive at a cellular level because there is no myoepithelium holding it back. Yet, we touched on this paradox at the very beginning of the deep dive. EPC is staged similarly to an in situ disease using the TIS classification.
Right, because the staging is based on clinical behavior, and EPC manages to contain its own invasive potential through a really unique stromal response.
Which is?
While the cellular retaining wall is gone, the expansile pushing borders of the proliferating tumor cells trigger a massive fibrotic reaction in the surrounding stroma. This creates a thick, dense, fibrous capsule that entirely encases the lesion.
It essentially built its own prison.
That's a great way to put it. It is structurally invasive, but clinically contained.
Incredible.
Yeah, as long as the pathologist confirms there are no microscopic foci of tumor cells physically breaking through that fibrous capsule and infiltrating the adjacent breast tissue, the prognosis remains excellent. It aligns much closer to DCIS than to conventional invasive ductal carcinoma.
Okay, so EPC gives us these delicate, slender fronds trapped inside a fibrous shell. But the spectrum continues to evolve, doesn't it? If those monotonous tumor cells proliferate so rapidly and densely that they completely choke out the arborizing architecture, the diagnosis shifts again.
It does. We move into solid papillary carcinoma, or SPC. Morphologically, you no longer see clear branching structures. The cells just grow in dense, solid, clustered nests.
What happens to the branches?
The underlying fibrovascular septa are still there, but they are incredibly inconspicuous. They're compressed into thin, microscopic lines by the sheer volume of tumor cells.
So it looks like a solid wall of cells on low power. But biologically, SPC introduces a completely new variable into the equation. The sources highlight that these cells frequently exhibit variable neuroendocrine expression.
You will often see positivity for neuroendocrine markers like synaptophysin, chromogranin, or INSM1.
That's wild.
It's a fascinating display of lineage plasticity. These are breast luminal epithelial cells that, under specific oncogenic drivers, have epigenetically reprogrammed themselves to take on a neuroendocrine-like phenotype.
So what does this all mean? We have this dense, solid neuroendocrine-expressing mass, and the sources divide SPC into in situ and invasive categories. If the internal structure is just a solid block of cells, how do you determine if it's contained or if it's actually invading the surrounding breast stroma?
We have to evaluate the extreme periphery of those solid nests. If the SPC nodules maintain smooth, well-circumscribed, rounded external contours, and an IHC stain reveals a preserved outer layer of P63 or P40 positive myoepithelial cells surrounding those solid nests.
That is in situ.
Exactly. It's classified as in situ. It has choked the internal ductal space, but it has not breached the primary duct wall.
So what changes when it finally becomes invasive solid papillary carcinoma?
The visual hallmarks of invasion are aggressive and chaotic. Those smooth, rounded borders are just lost. You see a geographic jigsaw pattern of tumor cells with ragged, irregular edges physically dissecting into the background tissue.
Does the surrounding tissue react to that invasion? Like, is there a response?
Intensely. You will see prominent desmoplasia in the adjacent stroma. Furthermore, invasive solid papillary carcinoma frequently produces abundant extracellular mucin.
Mucin.
Yeah, the tumor cells secrete this mucin, which accumulates at the leading edge of the invasion. It effectively acts as a dissecting medium that physically wedges apart the collagen fibers of the stroma, facilitating the infiltrative growth of the tumor nests.
So the mucin isn't just a byproduct. It's actively assisting the structural invasion.
Precisely.
And finally, at the absolute far end of the spectrum, we have true invasive papillary carcinoma.
Which is actually relatively rare. True invasive papillary carcinoma exhibits frank infiltrative growth deep into the surrounding breast parenchyma. It lacks any thick fibrous capsule or smooth borders.
So it's fully loose in the tissue.
Right. However, even as it aggressively invades, the tumor cells stubbornly maintain their arborizing architecture. They continue to build those complex fibrovascular cores and papillary fronds directly within the invasive stromal environment.
Wow. We have navigated a massive amount of structural pathology today. I mean, from the sturdy, dual-layered fronds of a benign papilloma, balancing their polyclonal ER and CK56 expression.
Yep.
We discussed the localized trauma of core biopsies causing infarction and the absolute necessity of excisional biopsies to hunt for that focal monoclonal DCIS hiding in the periphery.
Crucial step.
And then we analyzed the complete loss of the P63 positive retaining wall in encapsulated papillary carcinoma and its paradoxical TIS staging due to that thick fibrotic capsule. And finally, we tracked the dense neuroendocrine expressing cellular proliferation of solid papillary carcinoma, culminating in the ragged mucin dissecting borders of frank invasion.
The microscopic progression is undeniably intricate, but the clinical outcome data from the Royal College of Pathologists provides a highly stabilizing perspective for anyone diagnosing or treating these lesions.
In what way? Like, what's the takeaway for the patient?
Biologically, the vast majority of these malignant papillary lesions, whether we are talking about encapsulated, solid, or true invasive papillary carcinoma, they share a highly favorable receptor profile.
Oh, that's good news.
Very. They're almost universally strongly ER and PR positive and HER2 negative. They generally exhibit low mitotic rates and indolent growth patterns.
So despite the chaotic architecture and the aggressive terms like, loss of myoepithelium and stromal invasion, the underlying biology is highly receptive to targeted endocrine therapies.
Exactly. The complex histopathology shouldn't obscure the fact that these patients generally experience highly favorable long-term prognosis, significantly better than those with conventional high-grade invasive ductal carcinomas of the breast.
It is a critical reminder that structural complexity does not always equate to biological aggressiveness.
Now, to close out our analysis, I want to circle back to a specific molecular detail buried in the sources because it hints at where the future of this diagnostic field might be heading. Let me guess, you're thinking the PIK3CA pathway.
Yes, exactly. We noted earlier that PIK3CA hotspot mutations are present in up to 40% of structurally perfect, totally benign intraductal papillomas. But the data also shows that those identical PIK3CA activating mutations are found in roughly 20% of encapsulated papillary carcinomas.
The ones where the myepithelial layer has been entirely eradicated.
Right.
It establishes a definitive shared genomic lineage between the benign overgrowth and the malignant progression.
Which opens up a fascinating avenue for predictive pathology. Think about it. If we know that PIK3CA provides the initial proliferative drive, what is the secondary epigenetic or molecular trigger that ultimately signals the myoepithelial cells to undergo apoptosis and just vanish?
That's the million-dollar question.
If researchers can isolate the exact secondary mutation or micromolecular shift that degrades that structural retaining wall, we wouldn't just be diagnosing EPC after it forms. We could potentially sequence a benign papilloma from a core biopsy and predict, with pinpoint accuracy, whether its structural boundaries are destined to fail years down the line.
We would be moving from reactive morphological staging to proactive structural prediction.
It completely reframes how we look at an intact retaining wall on a slide. Just something for you to consider the next time you are evaluating those blunt fronds under the microscope.